Before I start, we don't have any disclosures at all in terms of financial supports or in-kind support, no conflicts of interest. We do have consent obtained from the patient and family for use of a case presentation today, and any medication recommendations that we talk about are considered off-label but within the guidelines. So our goals and objectives, we're going to be talking about catatonia. So we're going to review the background and the key features of catatonia. We're going to be talking about how catatonia can present in a child and adolescent population, speak around the pathophysiology of it, identify some challenges both in diagnosis as well as the process of treatment and guidelines. So key features of catatonia. It is a severe neuropsychiatric disorder that was first described by Baum in 1874, which is characterized by alterations in movement, speech, complex behavior, and often autonomic and affective dysregulation. In the 2023 review in New England Journal of Medicine, the prevalence is thought to be around 0.6% to 1.7%, but it's not clear. It is highly underrecognized, and there are rates around 6% thought to be prevalent in the neurodevelopmental population, as well as even rates around 10% around patients admitted to medical units. So likely to be much more common than we often see here in hospital. It's associated with a really high morbidity and mortality. Untreated catatonia is one of the highest morbidity and mortality of all pediatric psychiatric illness, with a 60 times increased risk of premature death. It was initially linked with schizophrenia, but now known to occur in a wide range of medical and neuropsychiatric disorders. This film that I started with, Awakenings, was speaking to catatonia due to an influenza outbreak of encephalitis lethargica. I'm going to move on to a case presentation that Dr. Dary and myself were involved with. This is a now 13-year-old male who presented when he was 12. He was previously healthy, had no family history or personal history of psychiatric illness, was actually attending a science and technology program, quite high-functioning academically, who after a couple weeks post a viral infection, abruptly began to getting lost at school. He was unable to find his locker. When he found his locker, he found himself kind of stuck and unable to move. He became confused. His movements slowed. His speech began to change from his normal tone to quite a dysphonic, screechy tone, and he began to have difficulties eating and swallowing. This progressed to some choreoform-like movements of his hands and feet, and he began to repeatedly do movements like tapping of his finger to his forehead and repeatedly hitting himself, and became to the point that he was unable to attend to any activities of daily living. This progressed to complete mutism and significant dehydration and weight loss, requiring admission to the stollery for both diagnostic workup, stabilization, and NG feeds. I'm going to turn the slides over to Dr. Dary here.
Yeah. So when he came into the stollery, with his presentation, neurology was quickly involved. And we'll go into sort of the diagnostic and investigations later in our discussion. But it was very clear with the acute onset that there was a high concern for a neurological process. When we saw him in hospital, much to what Dr. Stolte said, there was a lot of repetitive movements. He was essentially bedbound, a really sort of hyperkinetic. He had this reduced, altered speech. Initially, there was mutism, and then there was some speech. And there was this really interesting fluctuating course. So there was a lot of discussion amongst all of the different specialists in regards to sort of next steps of what would happen in terms of investigations and how we were going to support this boy in the hospital in determining what had caused such a rapid decline. Some of the interesting features when he came in is there were times where there would be a fluctuation to his symptoms, and I think that created a lot of diagnostic uncertainty. The other piece is that there were also autonomic instability. So there were times where he would become significantly bradycardic, even when he was hyperkinetic and moving and having these repetitive motions. And so it was interesting. It wasn't just happening like at night. And so cardiology was even consulted because of this concern regarding these transient heart rate drops down to like 45 or 46. He wasn't able to feed himself. There was significant difficulty with coordinating his oral motor movements and actually clearing food from his mouth. And ultimately, an NG was placed. So there was a coordinated effort of all the different specialties at the Stollery to work together to determine next steps in investigations and treatment for him. Next. So when we think about catatonia, if you look in the DSM, there's 12 symptoms. I won't go through them all here. They're listed on the side of the screen. But really for diagnosis, you need 3 or more of the symptoms. I think one of the important pieces is that in youth, there's often reduced verbal communication. Reduced oral intake is very common, stereotypies and agitation in excess of baseline. So sometimes we have to think about in children and youth what their baseline function is, because some kids, particularly those with neurodevelopmental disorders, may have baseline stereotypies or baseline agitation, or what some movements would be considered hyperkinetic, but is it in excess of that? The other piece is that within the child and adolescent population, we can see sometimes urinary incontinence show up, acrocyanosis, recurrent self-injury, and nudism. So those are things that aren't necessarily captured within the DSM. There can be a large amount of diagnostic delay, especially in neurodevelopmental disorders, because again, a lot of the time, some of the symptoms can be seen within that neurodevelopmental picture. So what's important is to establish that baseline, and are we seeing a significant movement away from that baseline in regards to these types of symptoms. So oftentimes when we think about catatonia, we often think of the stuporous kind. And those were sort of the videos that were shown. There was the one person who was, in that movie, who was posturing with their mouth open. We think of immobility, mutism, catalepsy, rigidity, waxy flexibility, those very sort of classic ideas of what catatonia is. But that's actually not how it always shows up, particularly in the child and adolescent population. We can see that at times, but oftentimes we actually see the excited form. So the hyperactivity, the stereotype movements, impulsivity, and they can be highly agitated and really combative. And sometimes when they present that way, there can be an assumption that this must be a primary psychiatric disorder. This must be some sort of psychosis, or this must be mania. But really, I think it's important to characterize those symptoms more to make sure that we are investigating appropriately for what may be underlying the catatonic symptoms. There's interesting overlap between NMS, so neuroleptic malignant syndrome, and what we would consider malignant catatonia. And then, as I mentioned, delirious mania also is another subtype. The periodic catatonia can be this fluctuation between stuporous and excited forms. We will see this sometimes in the neurodevelopmental population. And what can be challenging about it is when it does fluctuate, it's hard to quantify. And then there can be an assumption that, well, is this behavioral, right? This sort of statement of this is sort of intentional or produced for some other means. So again, it's really important to sort of keep our minds open about quantifying these symptoms, thinking about it from changes in baseline functioning. So here's the overlaps of where we can see there can be stuporous and excited together, and then you see there's periodic catatonia. Or if you have excited and malignant, you might have delirious mania. So again, not everyone fits into perfect boxes. Not every patient we see with catatonia fits into everything. And so if we have an understanding of having a very standardized approach and a way of monitoring the symptoms, that helps us create a bigger picture and understand what's going on when there could be such fluctuating symptoms. So I think the most important part in thinking about catatonia is it's possibly the only psychiatric syndrome for which the diagnosis absolutely relies on physical exam findings. more so than the clinical review. The clinical interview gives us a picture of baseline functioning, acute change, and what we're looking for. But that examination is really what helps us nail down all the different symptoms. The DSM, as you can see, we won't go through this whole thing, but it's just to represent the DSM only covers certain aspects of catatonia. So when we look at the broader understanding of catatonia, Dr. Francis was here in 2024 talking about the Bush-Francis catatonia rating scale, but it encompasses much more in terms of the different symptoms that we see. In the child and adolescent population, both the Bush-Francis and the Pediatric Catatonia rating scale have been validated and can be used. I think it's important for practitioners to choose a scale that they feel works for them, that they feel very comfortable doing and repeating, and either the Bush-Francis or the PCRS, the Pediatric Catatonia Rating Scale, can be used. So they're just much more extensive than just relying on the DSM criteria. So if we look at the Bush-Francis, it's positive if 2 or more symptoms are present over 24 hours. And so what's important is that sometimes we may do the assessment and it doesn't quite meet criteria, but then you do it later in the day and it does. So it is something that needs to be repeated. It can be used for initial diagnosis and to monitor treatment response. And it's actually very helpful for monitoring treatment response, especially when there's so many different symptoms and when we're trying to fine tune if the intervention is being helpful. The full scale is 23 items. The first 14 is the screening instrument. If 2 or more of the first 14 is positive, then it's considered positive screening and you complete the remaining 9 items for a total of 23. It only takes about 5 minutes to complete. And when you do it regularly, it's not so onerous. This is what it looks like. Most of the all of the different points that you score it on are from 0 to 3 generally, and then you just add it up at the end. So it's not so difficult to do. This is the appendix where it actually gives you the way in which you conduct the physical exam. Now, when I do this, I typically will pull the parents outside of the room, explain what I'm going to do, because the physical exam is an odd one sometimes, because you're asking the patient to do things and then you're kind of sort of tricking them in a way, and you're really looking at, are they going to follow your commands without even thinking what you're saying? And the classic one of, you reach into your pocket and you state, stick out your tongue, I want to stick a pin in it. That can be scary for parents to hear. And so you can modify it. I think Dr. Stolte uses like, shake my hand, I have something sticky on my hand. There's ways to test for automatic obedience that doesn't include that statement, but explaining to the parents what you're doing and why you're doing, I think, is really important. And so that they also don't intervene when you're doing the physical exam. So if you look up the Bush-Francis online, it's all there. You can practice it. You take in the instructions with you and you just go through it. And it's not onerous to do it. It doesn't take that long. And so it's nice to do it before for diagnosis, and then before an intervention and after an intervention.
Thanks, Kim. Yeah, we're now going to move into etiology. And the biggest piece I want people to take away from this is that catatonia is never a standalone diagnosis. There is a wide range of underlying causes. I often think of it more as a symptom, even though it's a syndrome, like in the same way that fever you can treat with Tylenol or ways of cooling the body down, but it has a wide range of causes underneath it. Catatonia also has symptomatic treatments, but always has an underlying diagnosis that is actually a fairly broad differential. It can occur at the extremes of all psychiatric illnesses, including PTSD and OCD, which are not often thought of, but more commonly, about a quarter of catatonia are caused by underlying bipolar or affective disorder. About a quarter is caused by schizophrenia, and about a quarter is caused by medical illnesses. Of these medical illnesses, 70% end up having an autoimmune cause to it, or autoimmune encephalitis. and I will talk more about that. And the remainder of the etiology is a range of ASD or neurodevelopmental trauma or other psychiatric symptoms and disorders, as well as substances. As I mentioned, there's a pretty broad list of medical conditions that can present with catatonia, and so the organic workup is important, as well as the history to look for substance use, new medications that might be on board, history of past medical illnesses, as well as a full physical exam and blood work, as well as MRI and EEG. In general, the younger the patient is presenting with catatonia, the higher the risk of it being a medical condition, as opposed to when it occurs in the adolescent stage, where we are often seeing our first presentation of bipolar or schizophrenia. This is a really interesting systematic review of causes of catatonia. What they found was that there's a pretty high evidence for involvement of the immune system. Um, and the majority of these are NMDA receptor encephalitis, but there's also other forms that the immune system can end up triggering catatonia and can be included both within lupus, thyroid, MS, as well as PANS pandas. On the side here, they went through a review of a wide range of infective agents that can trigger catatonia, including both EBV, group A strep, mycoplasma, West Nile. And there's a debate around whether this is due really from direct infection, which they think is less likely, as opposed to damage secondary to an immune reaction. It was interesting, after adding in this video for awakenings of that movie, encephalitis lethargica, there are now some new cases that are reemerging. And when they've been evaluating them more recently, they found that a high prevalence of these actually have NMDA receptor encephalitis or anti-D2 autoantibodies. So the thought is actually it was an immune-mediated catatonia. There also have been cases of post-COVID inducing catatonia. We've seen this on the unit, and I think it's worth just mentioning, given our situation with COVID, that we are seeing this more as well, and does seem to be an immune triggering agent. I'm going to go back to the case and actually let Dr. Dary talk through what went on at Stollery in terms of investigations and findings.
Do you want to play the video first? And then
Sure.
because I think
Yeah,
the video is, yeah.
we'll do that.
Look at it, look at it, that, yeah, look at that. Can you look up? Okay, keep your eyes open, okay? Okay, grab the ball. Try to close your hand. Try to close the ball. You got that? There you go, there you go. Okay, now, give it back. Don't drop it, give it back. Okay, raise your hand. Just hold, just hold. Raise your right hand, keep it straight, try to keep it straight. Don't move it too much. Now go back down, get the ball. Keep your hands open. Fully. Close it fully. Fully grab it. There you go. Now raise it up. Keep holding it. Keep holding it. Raise it up. Okay, give it back. Don't drop it. Good job. Let's try with this one. Fully grab it. Fully grab it. There you go. Good job. Now raise it up. Keep it. Keep it steady. Keep it steady. Good job. Now give it up. Good job. Good.
So I think it's important to see that because when we're observing, that's actually when he was doing a little bit better and he was able to follow commands. But you can see how a lot of people might go in and say, well, this is a neurodevelopmentally challenged child. Like there's some sort of delay and this is baseline. But mom had incredible video of like a few months prior of him interacting with his friends. And that was really helpful in piecing together this picture of how he was doing. So At the Stollery, many specialists were consulted, as I had mentioned. It included neurology, pediatrics, cardiology, metabolic genetics, psychiatry. There were very specific things on his neurological exam that really sort of triggered neurology to do the bigger workup. There was the milkmaid grasp to his left hand. He had some choreiform movements, saccades of some cranial nerves. He had difficulties, as I had mentioned, with oral motor functioning. And then this sort of high pitched and unintelligible vocalizations. So, neurology really thought initially that they were concerned about an autoimmune encephalitis, particularly anti NMDA. And their differential included side and ham chorea or other limbic encephalitis, lupus cerebritis. And then they thought less likely infectious or toxic etiologies. Initially, his Bush Francis. He had 19 out of 42 on screening, but it was the 30 out of 69 severity score that improved eventually to 10 over 69 when there was initiation of lorazepam. But he had many workup, like a full workup completed, including looking at his cerebrospinal fluid. There was an MRI, there was a PET scan, an EEG, and the MRI showed some abnormality, but the repeat was normal. And the PET again showed some things consistent with autoimmune encephalitis, but the reports will often also say these are non-specific findings. So there wasn't anything, and nothing came up in his CFS that was really like, this is NMDA. That actually came back as negative, and his EEG was normal. What was abnormal was an anti-strep titer, and there was EBV IgG positive. And so there was sort of this remote history of maybe some infectious prodrome that had happened, a month or two prior to the deterioration of his symptoms.
Thanks, Kim. We're going to talk about pathophysiology of catatonia now. And when I think of that, there's three main areas that we look at that we know are abnormal with catatonia. The first one is a disrupted immune system. So catatonia on its own does have significant changes in the immune, both adaptive and innate system. There's increases in microglia, there's signs of neuroinflammation, there's elevations of cytokines, there's increased permeability. And so we know that the immune system is actually highly dysfunctional when we see catatonia. The other piece that we see is network dysfunction. And this is also quite interesting because there's difficulties with the interconnections between the frontal and the subcortical circuits. So the planning area of the brain is actually quite disconnected from the motor control and the executive functioning, which is why you can see a wide range of areas such as ambitendency, where somebody's trying to get out of the chair, but they're stuck, or they're trying to lift up a spoon, that actual initiation is lost between the finishing of the motion. You also see those movements that somebody is unable to stop. So the repetitive stereotypies, the agitation. The neurotransmitter system is also quite interesting. So there's significant reduction in your GABA system. So you have less inhibitory neurotransmitters. You do not have the same amount of these neurotransmitters to stop an action. We also know that there's excess glutamate, and so there's excess excitatory. And within the basal ganglia, there's also reduction in dopamine. And so these patients can look like they have Parkinson's disease. They have the slowing of the movements. They have the masked faces. They have these tremor, almost like movements in their hands. Like there is a wide overlap there. It's not just the basal ganglia, but with that reduction of dopamine in that area, patients can look very similar to this. And catatonia has a high complication rate. 20 to 46% of catatonic patients will have some complications. And you can think of it on the two extremes, with the stuporous catatonia, many have complications because of immobilization or malnutrition or dehydration. The bowels themselves can slow down. We see this all the time. Patients who never had troubles with constipation are now profoundly constipated, needing enemas. You can get urinary retention. The whole system starts to slow down. And then on the other side, the excited catatonia, with the excess motion or the posturing, there can be a lot of harm with regards to um, both high CK, even there can be cardiac involvement, rhabdo can occur, and it can also risk malignant catatonia. If you shift into malignant catatonia, there's actually a 23% mortality rate, which is very, very high. And so early diagnosis and treatment is critical. I show this slide here because if we can back up into the presentation of this case or other cases that we see that come through the emerge or through the hospital, often it's very difficult diagnostically, especially if you have agitation, combativeness, repetitive movements. It's not uncommon for us to consider using antipsychotics to help ease that agitation. But then if we think about the pathophysiology, if this is actually catatonia, already these patients have low dopamine, high glutamate, and they're at a real high risk of developing both EPS and Parkinsonian features, and actually shifting into malignant catatonia. And so we need to have a very high suspicion for catatonia. Both for treatment, but also for use of PRN medications, which may worsen the overall underlying illness. So what is our treatment? Well, first we want to target the catatonia symptoms. The first line of that is high-dose lorazepam, and with this, we're actually replacing the deficient GABA in the system. As opposed to the other times that we use lorazepam, where it can cause sedation. If you treat somebody with catatonia, they have a remarkable ability to tolerate Ativan. They do not get sedated. Actually, they begin to speak, they begin to clear, their movements become smoother. And it's because you're replacing that deficient neurotransmitter that's highly deficient in the system. If this fails, our second line is electroconvulsive therapy, which is highly effective at 80 to 100%. And it both works by downregulating the immune system overactivity, as well as normalizing the neurotransmitters, as well as improving connectivity, neuroplasticity at a wider range. The other target of treatment, though, is assessing and finding underlying cause, whether that be an organic medical condition, a mood disorder, schizophrenia, or trauma, monitoring and treating any complications which can arise, and of course, avoiding antipsychotics, which can worsen catatonia. And one more comment on that, the more potent your antipsychotic, the more intensely it binds the D2 receptors, the more likely you are to cause harm. And so if you were to require some other agent within the antipsychotic category, we generally would pick something that is a less D2 blocker, such as maybe olanzapine or loxapine, and going very carefully with it.
So the one thing I wanted to bring up that I missed on the one last slide at the Stollery, and this ties into what Dr. Stolte just said about treating catatonia. Sometimes it's difficult to know when to start treatment because when we're in the process of investigating for an etiology, and so when neurology wants to start treatment for the underlying cause, so if they think that it's an encephalitis and are considering steroids or IVIG, there's always a question of if we add something in like lorazepam to treat the symptoms, are we going to confound the picture and confuse it more with improvement of symptoms? And will we attribute that to the intervention that was given for the underlying illness, or will we attribute it to the lorazepam? So there's always this discussion. And in this case, with this boy, there was actually a bit of a delay in giving lorazepam. It was, I think, a bit of family preference to see if the other interventions were going to help first. And so finding that timeline of when to intervene, I mean, the research would show that you intervene early, but when you're examining for the underlying etiology, there's just a little more complexity. And if there's sort of open communication amongst the teams of what we're looking for, are we making sure that the patient is safe? Have we covered everything else of all the complications of catatonia? And then we sort of decide the treatment algorithm moving forward. That being said, sorry, Dr. Stolte, there is evidence-based guidelines for catatonia, but these are geared towards adults. So right now we don't have sort of consensus guidelines that have been made specific to the child and adolescent population. The American Psychiatric Association also has their resource document with catatonia. They have their stepwise approach of lorazepam or other benzodiazepine, ECT, consideration for a glutamate antagonist, antiepileptics if needed, and antipsychotic agent. And as Dr. Stolte had said, looking at a low potency. So those, again, are part of the adult world. So within the American Academy of Child and Adolescent Psychiatry, over the past few years, there has been a group of mainly consultation liaison child psychiatrists who have been working in a catatonia working group to really try and gather more evidence and more information to create guidelines for child and adolescent psychiatrists in the treatment of catatonia. Part of this, like there have been some publications of site-specific guidelines, but part of it was actually to create consensus guidelines. And so there was a group of us who worked together. There was 15 participants across 14 institutions in both Canada and the United States. And we did sort of a Delphi method of gaining consensus over multiple iterative surveys to create these guidelines. So this is just an infographic kind of summarizing it. And there's a lot of information in here, and a lot of it is actually geared towards how do you manage in the acute phase. So when the patient comes into hospital, what are we looking for? What are the things that we need to think about for pathway initiation? And then how do we do the initial screening and assessment? So you see the Bush-Francis or the PCRS is used. If they're in ICU or there's sort of, significant concerns about needing ICU, we also incorporate a delirium scale. And then we have the recommendations of all the different diagnostic evaluation that is recommended. Obviously, this is often expanded based on case indication. So this was sort of some of the general consensus that we had come up with just in the first parts of the pathway. We can switch to the next slide. And then when we think about the continuing care delivery that's needed in hospital, they need psychiatric follow-up, but they also need medical follow-up. We're thinking about their nutrition status, their vitals. Do they need significant support with seclusion or restraints? How are we managing all of those symptoms? And when to transfer to critical care? When is it appropriate to transfer to psychiatry? So these were all the different things that we had looked at and come up with a consensus around. In terms of management, this doesn't differ significantly from the adult population. The first line treatment is lorazepam. Whether you treat with IV or IM or PO can depend on a lot of different factors, and you'll see them listed there. I think what's important to know is that in Edmonton, we are very, very lucky. And I'm thankful to Dr. Stolte and to Dr. Parsons and those who've continued the ECT program at the Royal Alex. We are very lucky to have access to ECT. In speaking with colleagues, particularly across the United States, where it's sort of state designated whether or not children and adolescents can even have ECT. It's interesting to see that they've said there's no maximum daily dose to benzodiazepines when ECT is not available. And the maximum daily dose is dependent on side effects and ECT availability. So we will often titrate up to what would be considered high doses of benzodiazepines. But as Dr. Stolte said, there is not the side effects of sedation, but rather improvement in the catatonic symptoms. ECT is the next best step when there is limited or no response to lorazepam. It should be pursued regardless of accessibility. And this statement was put in as part of advocacy towards access for ECT for children. Emergent ECT is needed if there's significant autonomic instability and organ failure, severe rigidity, unconsciousness. And as Dr. Stolte had said, there is a consideration for low potency antipsychotics. Within our group, it was decided that quetiapine was preferred as the low potency, but I think as long as we're mindful of making sure that we're not causing any significant side effects or pushing into that NMS picture with the use of antipsychotics. Next.
Okay. Yeah, thank you, Kim, for that. And just one comment on the Ativan dosing. You know, we've had patients that have needed to get into the 20, 25 milligrams, even 30 milligrams of Ativan in a day. Even younger children have required this kind of dosing, which is pretty incredible, with still no sedation. So it's quite a unique condition and a very, very unique response to Ativan. And it's just worth noting those ranges that sometimes are needed. So back to the case. So this little kiddo was transferred to us under my care and did have a lengthy admission. I think it was 7 months from the start of the stollery to when he finally went home. When he first came under our care, his Bush Francis was in the 14 realm. He now was eating and drinking and didn't require tube feed, but his voice was very dysphonic and difficult to understand. He had repeated stereotyped flapping-like movements of his hands and repeated tapping of his head. He would say words that were clear were words like sorry, 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 sorry. He had a very hunched over posture and it fluctuated. You know, he really did look like a severely disabled child. And then at other times was seen to be smoothly walking, laughing, and joking with his friends, which you can imagine would raise the comments such as, could this be behavioral? Could this be an act? But it certainly was not. This was moving outside of his control. We did optimize his Ativan first, up to 16 milligrams per day, but he was having some nausea at that dose and some gait instability and was still continuing to have catatonic symptoms. And so from there, we did discuss ECT with his family, which we provided bilateral ECT with their consent, and it resulted in complete improvement of the catatonia. It was quite remarkable. But what we noted was that in the ECT suite, which we provided these treatments 3 times a week, prior to giving the treatment, we have to use a medication called flumazenil, which reverses the benzodiazepines in the system completely so that we can actually give somebody a seizure. And the child would be chatting with us, very cute, kind of laughing, joking, and as soon as the flumazenil would hit him, he'd be stuck. He wouldn't be able to talk. He wouldn't be able to move. I'd say, can you look at me? He wouldn't be able to shift his head. All he could do was blink. And that was quite interesting to show that underneath this all, when the benzodiazepines are not in his system, he was a very, very ill child that with these treatments was able to function. And the other thing that was quite interesting was that when the catatonia resolved, what also came out was that this child had symptoms of OCD that had never been there before his illness. He had intrusive thoughts, he had worries about harm, he had rituals and things that he had to do over and over again, which was not treated by the Ativan or by the ECT. We started him on antibiotic as well as naproxen to target the group A strep, which he had a very high ASOT. He himself, we were not able to identify strep in his throat, but his family did end up coming back positive for strep. And group A strep is known to create, unfortunately, immune reactions where there is both abrupt onset of OCD as well as catatonia. And so our best working diagnosis was that this child had strep, which caused an immune reaction, which triggered both the catatonia and the OCD. And the other supporting symptom of that was when he was in the stoller, he had also milkmaid grasp, as well as some subtle Sydenham's, and so some physical exam findings that are also associated with strep. And so we initiated him first on the antibiotics, the naproxen, and the ECT, and he did quite well. However, when we tried to back off on the ECT, he had profound deterioration. Again, the mutism, the repeated stereotypies, the reduction in both the speech and the ability to eat and drink. It also coincided, unfortunately, around the time that we suspected that the IVIG and methylprednisone, which had been given in the stollery empirically out of the concern for a possible autoimmune encephalitis, had been wearing off. So around, I think, between weeks 4 to 6 after this, he started to deteriorate again, and he did require repeat doses of IVIG and methylprednisone with very prominent improvements after this. Eventually, with repeat rounds, we decided to give him rituximab as a maintenance agent. And he, with that, once that got to a therapeutic level, I did have full recovery. It was quite interesting because as we were backing off on ECT, it was a nice sort of telltale sign. And when we gave him the flumazenil, what would happen to this kiddo? Would he be able to speak with us? Would he be clear, or would he regress into catatonia? And as the rituximab built into his system to about that 8 week, that was when we started to see that when we gave the flumazenil, this kid was actually fine. And that gave a lot of confidence for us to completely back off on the ECT altogether and to allow him to be safely discharged home. And so he's now home. He is doing remarkably well. He had a full recovery, even cognitively a full recovery, back to his academic school, and is not needing any treatments for catatonia. He is on no benzodiazepines. He's on no ECT at this point in time. He's still on antibiotics and naproxen, and he's on rituximab, which really was the key agent for him to be able to maintain recovery. The symptomatic treatments of catatonia were able to get him well, at least transiently, but the underlying cause was continuing to cause problems every time we backed off until we were able to get that agent on board for him. Unfortunately, that agent is not approved through our Alberta Health Services STET program for PANS PANDAS. It is approved for clear autoimmune encephalitis, but some of these more obscure triggers for catatonia are not on their diagnostic list, which makes sense. But it did mean that this family had to pay privately, which was a difficult decision for them, but ultimately resulted in his recovery. So I want to just show you a video that he wanted to share with everybody in a follow-up meeting with myself. So I'm asking about catatonia and how's his experience.
It felt like that, it was very harsh. I couldn't really think anything or talk really about anything, or I could only just watch and wait until the time goes by. I couldn't do as much things that I could have when I didn't have catatonia, and it was very I just sat still in my bed and just doing and I couldn't talk, and I did random things, movements, and it was not too fun because I had to stay in the hospital. I couldn't go home. I couldn't play with my friends. Couldn't go to parties, family friends' houses, and school especially, and my own house.
Yeah.
Or
were you aware that you were stuck and couldn't do these things?
A bit, but mostly it just happened for some reason.
Yeah. And do you remember back to times what it felt like?
Not too, because mostly I also catatonia. It makes you forget a bit too.
Yeah,
a lot.
That's true.
Not a lot, but little bits of parts of memory. So yeah. But it was I couldn't really talk. I could see what's going on, but I couldn't understand or think what do I do, or how do I do it, and I couldn't explain anything because with catatonia at that time I couldn't really talk. But now that I don't have catatonia anymore, well, I basically don't have catatonia anymore.
Yeah,
There's
I think
some
you've
treatments
recovered.
Are still going on just in case, so catatonia doesn't come back. But now I'm way better. I can actually express myself and show and I can also teach by moral precept my moral, like what happened and like how I recovered from it. Everyone's like surprised and like happy for me that I recovered from catatonia. And like, yeah, and like it was very good to be back to normal and my normal day in a normal life. And that was very fun too, because like now I didn't have to stay stuck in a room.
Yeah, fair.
And just sit in the bed.
And what things have you gotten back to in your life? What are some of your favorite things? Tell us.
Like coming back to school,
Yeah.
everyone missed me because I was gone for 7 months in school. And all of my friends are like, "Where have you been?" And like coming and like everyone, all of my teachers, the staff members, all of them missed me. And now we're it's back. It's now like basically back to a normal day of school. And
Yeah, so it's really delightful to see this kid doing so well. It was interesting. During these fluctuation times, he would tell me sometimes the catatonia felt painful, that he felt stuck, that he could almost suppress it during certain times, but it was painful to be stuck like that. So I'm just going to go through some conclusions and overview here. So in conclusion, catatonia is a severe neuropsychiatric disorder. It's often underrecognized. It can be caused by a wide range of causes and does require full assessment both for medical etiology as well as psychiatric etiology. Early assessment and treatment of catatonia is crucial to reduce morbidity and mortality, but I agree with Dr. Dary that the timing of that is tricky because you're trying to tease out, response to underlying cause and response to catatonia treatment themselves. A Ativan trial is something that can be quite useful early on, just to see, is there improvement with Ativan or is there sedation? Diagnosis requires a specific assessment and physical exam. It's really helpful for us to utilize scales like the Bush-Francis or the PCRS, both initially as well as to look at tracking treatment with time. And high-dose benzodiazepines and ECT are the mainstay of treatment. But it is important to identify and treat the underlying cause in order to achieve and maintain recovery. So thank you everybody for your time. Here's some additional citations if you'd like to do some reading. I will be sending the slides to Alice just with the case removed as a PDF if anybody would like to read it later on. And we'll open it up to some questions.
So thank you very much to the two of you for this interesting and comprehensive presentation with your great case study. And I think there were some comments in the chat, appreciating your amazing case and wonderful presentation. So before we go into Q&A, just a reminder for people to complete your evaluation, and also that these rounds are accredited with the Royal College of Physicians and Surgeons of Canada and the College of Family Physicians of Canada, and hopefully you're getting your CME certificates as well, but please contact us if you're missing this. So we do have some questions in the Q&A, and the first is, do you have any recommendations for ambulatory clinics who are following up with patients who have been diagnosed with catatonia? Any tips or red flags?
I have a couple, and then maybe Dr. Dary does as well. One is that as we're backing off on the benzodiazepines, we need to go really slow and careful because we commonly will see recurrence of catatonia, especially if we have a psychiatric illness that is present. If you have another medical condition that you've easily identified and you've treated and it's now gone, then you can often back down with more confidence. But a slow, careful wean with a very close eye for recurrence of catatonia is necessary. The other comment is that I know that there are some clinics that treat primarily more neurodevelopmental disorders with excited catatonia, and they will track They will track progress also around, severity of injury, both at home or with the youth, and titrate Ativan to see if there's a response that way. The other piece that could be, of course, useful is having those rating scales available so that you know where you're at as you're going. And even like I have educated the families of patients with catatonia on the symptoms to be looking at, and I've done Bush Francis in the room with them because I'm not there with the kid the whole time, and I want a more longitudinal look at how this kiddo is doing, especially if there's a fluctuant course. And so we'll talk through these symptoms as I'm scoring it. And I think that helps family be more attuned to what to be looking for also. That's my piece. Kim, you probably have a lot more to add.
No, I would agree with everything that you said. Interestingly, in the US, there is a psychiatrist who has a telepsychiatry clinic for neurodevelopmental patients. And he recently published efficacy of telepsychiatry in assessing catatonia. And I think a lot of it has to do with, like you said, Dr. Stolte, the family having awareness of what to look for. I think for a lot of these families, once they go through it, they really do have a sense of what the symptoms are, and that you can adapt the Bush Francis and do it over telepsychiatry in different ways. And I think as long as we're sort of that standardized scale and being very mindful and slow, as you said, would be the tips.
Thank you. We have other questions. Is there any ability to advocate for biologics coverage for low-income families?
That is so hard. And it is an area that I'm struggling with. We don't have a good solution yet. My hope would be that maybe we could set up like a fund, like a foundation type fund for families that are not able to pay for it privately, that then we could use those resources for these children. Um, but right now we don't have anything set up. I'm open to ideas. If anybody wants to connect with me, that would be great. I've advocated strongly through the STET program, but I do get it. They get a lot of requests from multiple different specialties for biological agents for a wide range of conditions, and we're getting into fairly obscure with some of these ones, like a streptococcal induced catatonia. It's pretty rare. So. Um, yeah, long and short is I don't know yet. I'm open.
Maybe with the Alberta Medical Association and APA and SCAP to consider. Um, uh, Definitely worthwhile. Okay, what is the best way to access outpatient ECT if needed?
Um, well, there's a number of providers here in Edmonton. So myself and Dr. Mitch Parsons and Dr. Sampan Gautam are the three main providers here. We'd be happy to do a consult first and then set them up on the ECT list. Often here at the hospital, we do two opinions from psychiatrists before moving ahead with ECT. So this would provide another opinion for whether ECT makes sense, and then we would just book them in. Yeah.
Okay, thank you. And then Dr. Rabi, uh, excellent talk and presentation. Also, thanks for all your hard work in championing these patients. Have you found more acceptance and awareness of this illness over the last several years?
I'd say yes. I'd be curious with you, Kim, but I have been really pleasantly surprised with some of these cases that we hear coming through the Stollery where neurology is like, hey, this is catatonia. We had another one come through of this little kid who hadn't spoken in years, and they were using Ativan to be able to get enough sedation to get an EEG. And this little kid started singing and talking. And what I hear is that the neurology team came down and they were all very excited that this is catatonia. So I I feel like it has been growing in awareness and recognition. I think it's still under-recognized. There's lots of other cases, still the majority, where it takes quite a long time before these children are recognized or diagnosed. Even with this little one that I'm sharing, that took a number of years. But it does seem to be talked about more, and I'm seeing more cases where it's spoken about by my medical colleagues. So that's great.
And how would you do an outpatient referral if, let's say, someone in the community, because I'm noticing we have a diversity of people who attend these rounds in terms of, let's say, referring for, consultation for this, if, let's say, they suspect this diagnosis.
Send them to Dr. Dary. She's the best.
Okay, I guess people have you on their personal phone list.
That's complicated. Accessing all of this is always complicated because we don't have a designated like catatonia clinic. There's always challenges within the system of providing care. I'm very hopeful that in 10 years' time, when there's a new children's hospital, we will all be co-located. And so then provision of psychiatric and medical service can all be together, including ECT, because I think that's very much needed for comprehensive care for both inpatients and outpatients.
For sure, on call. I agree, Dr. Van Riper. On call and urgent clinic, if you're in the community and you need some support that way, if they're not connected, I would
you would
start with
actually have
that.
via switchboard, so asking for the child psychiatrist on call, and then they can consider whether urgent clinic is possible, and probably in consultation with the two of you, if you could do an urgent consult as well. Okay, well, we're at the end of our time, and so thank you very much for this fantastic presentation. You got lots of kudos and appreciation in the chat there, so you might want to take a look. And thank you so much for presenting and answering all our questions.
Welcome. Thanks for having us.
You're welcome.